First, artificial intelligence. We are already using AI to read mammograms, predict sepsis, and recommend chemotherapy regimens. These tools are powerful, but they suffer from the black box problem. We know the input, the patient's data, and the output, the diagnosis. But we often don't know how the AI reached its conclusion. It uses patterns too complex for the human brain. This creates an informed consent crisis. How can a patient consent to a treatment plan recommended by a machine if even the doctor can't explain why the machine chose it? We are asking patients to trust math they cannot see. The second problem with AI is bias. AI is trained on historical data. If the history of medicine is racist, and we know from Tuskegee that it is, then the data is biased. If an AI learns from data where black patients were undertreated for pain, it will recommend undertreating black patients for pain. It essentially automates and cements historical injustice. We saw this with algorithms used to allocate care management resources that prioritized white patients because they had higher past healthcare spending. Implementing such a system violates the principle of justice. We need algorithmic vigilance to audit these tools before they are deployed. Then there is automation bias. This is the psychological tendency to trust a computer over your own eyes. If the AI says no sepsis, but the patient looks septic, a young doctor might hesitate to treat. If they follow the AI and the patient dies, who is liable? The doctor for being a robot, or the developer for writing bad code? Currently, the law holds the doctor responsible. This creates a terrifying double bind. If you ignore the AI and you're wrong, you're negligent. If you follow the AI and it's wrong, you're negligent. This pressure threatens to erode the art of medicine. Second, let's talk about genetic privacy. Millions of people have spit into tubes for 23andMe. They think they are just finding out if they are Irish. They don't realize they are effectively ending the privacy of their entire extended family. You cannot de-identify genetic data. It is inherently unique. And because you share DNA with your relatives, when you upload your data, you're uploading theirs too. You are making a decision for them without their consent. The Golden State Killer case proved this. The police didn't have his DNA on file. They took DNA from the crime scene and uploaded it to a public genealogy database, GEDmatch. They found his distant cousins, people who had never committed a crime but had taken a harmless DNA test. By building a family tree, they narrowed it down to him. While catching a killer is good, the implication is that genetic anonymity is dead . If you have a cousin who took a test, the government can theoretically identify you. We have moved from a world where privacy is a right to a world where privacy is statistically impossible. Finally, the mature minor. Historically, children had zero autonomy until age 18, but we have carved out exceptions. In most states, adolescents can consent to STD treatment, contraception, and addiction treatment without parental notification. This is a public health carve-out. We want teens to seek help, and we know they won't if their parents are called. But we are seeing a push to expand this. Should a 16-year-old be able to consent to vaccines over parental objection? Should they be able to consent to gender-affirming care? Or refuse chemotherapy? Consider the case of Dennis Lindbergh. He was a 14-year-old Jehovah's Witness with leukemia. He refused a blood transfusion. Usually, courts order transfusion for minors, but the judge visited Dennis. He found him to be articulate, mature, and deeply religious. The judge ruled he was a mature minor and allowed him to refuse. Dennis died. This case represents a radical shift, recognizing that a 14-year-old might have the capacity to make a life and death decision. It challenges the bright line of 18 and asks us to look at the individual capacity of the child. We also face the unraveling of the definition of death. Jahi McMath was a teenager declared brain dead in California after a tonsillectomy. Her family refused to accept it. They argued she was still alive because her heart was beating on a ventilator. They moved her to New Jersey, the only state with a religious exemption for brain death. She was kept alive on machines for years. This case shattered the medical consensus on death. It showed that biology is not enough. Death is a social and legal construct. As technology gets better at sustaining bodies, the line between life and death will only get blurrier. To wrap up Module 4, clinical ethics is fundamentally about power. Who has the power to decide? Historically, it was the doctor. Then, after Dax and Quinlan, it shifted to the patient. Now, it is being dispersed to algorithms, data clouds, and complicated legal constructs. As policy analysts, your job is to ensure that in this high-tech future, the human voice, the voice of Dax screaming in the burn unit, or the voice of the frightened teenager, is still heard. Next week, in Module 5, we face the hardest questions of all. We have spent this week assuming that if a treatment exists and you want it, you can have it. But we live in a world of finite resources. There aren't enough organs. There isn't enough money. Who decides who lives and who dies when the cupboard is bare? We will discuss distributive justice and the rationing of care. I'll see you then.